everyone, and welcome to our first webinar from the AHRQ Academy. The AHRQ Integration Behavioral Health, the Academy for Integrating Behavioral Health and Primary Care. And we're really excited to have you all joining us today for our first webinar of 2026, where we're talking to 3 experts in the field about integrated behavioral health and action and really hearing from them about trends in the field. Thank you for joining us today. Just a quick overview of what we'll touch on today. I'll give a little bit of overview of IBH and the AHRQ Academy. I'll introduce our 3 excellent speakers today, and then they'll each give a brief presentation, and we'll follow that by a moderated panel discussion with some comments that you all submitted while registering, and then we'll also leave time for audience questions, so please put those in the chat. And then we'll follow up at the end with just a couple of closing remarks. My name is Annie Roble. I'm the project director for the Integration Academy, and I'll be your webinar host for today. And a little bit later, I'll be joined by Dr. Jody Palaha, who is our principal investigator, and will be our webinar moderator for the moderated discussion session. She is our PI, as I mentioned, and she's a nationally recognized leader in integrated behavioral healthcare. She currently directs the Institute for Integrated Behavioral Health at East Tennessee University and has many, many years of experience in clinical and academic settings with integration. So we're very excited to have her today on the webinar moderate this discussion. So we know most of you know what integrated behavioral health is, but we just want to sort of level set here and let you know that it's really that practice team of behavioral and physical primary care doctors working together with patients. And our work at the Integrated Behavioral Health Academy, we really focus on integrating that mental and behavioral health care within the primary care functions. And why do we do this? There's a lot of importance to doing this: provider satisfaction, patient satisfaction, reduced healthcare costs, as well as healthcare utilization, such as emergency department visits, and overall improving quality of life for patients and patient outcomes. So what is the Integration Academy? Well, we're a website, and you can see our website there at the bottom. Our team manages this website with a lot of resources, tools, toolkits, as well as playbooks for how to get started with integration, why to do integration, how to do integration, bridging that gap between what is integration and why we do it, and what are those expected outcomes. You can visit our website if you haven't already, although many of you registered for the webinar through the website, but it's integrationacademy.ahrq.gov, where you can see the resources we have, as well as webinars, previous webinars, topic briefs, as well as you can see the sections on the top there, some expert insights, as well as recent news and events around integration. So without further ado, I'm going to introduce our 3 speakers briefly here, and then let them introduce themselves a little bit more in detail. So we have Sara Barker here from the Ames Center, Dr. Jeff Reiter from Whole Team Consulting Services, and Neftali Serrano from CFHA. We're really excited to have this engaged group of presenters talk to you today. We're going to start with Sara, and she is currently at the Ames Center, as I mentioned. She's the Associate Director of Implementation and partners with policymakers, payers, and virtual care platforms to implement integrated care strategies. She's worked at a ton of at the CMAR Community Health Center, but has a ton of experience in integration prior to this role. And so we're excited to hear from her today. So Sara, I'll turn it over to you to give us a little bit background.
Great. Thank you so much. Thanks so much for having me today. Excited to talk about implementation trends in the field. You can go ahead to the next slide if you'd like. So before I kind of dive into what we're seeing around kind of collaborative care implementation and what we're seeing in the field, I just wanted to take a step back and think about, as we're thinking about behavioral health care and behavioral health care delivery, how we think about it now as like part of an ecosystem in which all the different components can play an important beneficial role, and how it's pretty fluid. People are really moving these days when they access behavioral health services across different settings, whether that be medical settings, specialty behavioral health settings, community settings, or self-care. If you look at the bottom of the slide, self-care is at the bottom. You know, more and more people are getting access through non-traditional healthcare delivery systems, whether that be things like digital therapeutics or community supports. Our focus at the AIM Center and what we're focusing on today is this green setting, the medical care setting, and really thinking about how do you build capacity to address behavioral health needs in medical settings. I would challenge all of us to not just think about it as there's one solution or one approach, but how do you layer different types of integrated care approaches, whether that be things like case finding and panel management, PCBH, collaborative care. Maybe you're also utilizing community health workers now to address social drivers of health. And so really thinking about what are your goals in the medical setting and what are the patient needs, and what is the capacity you're kind of trying to build. And then finally, the blue section of this ecosystem is specialty behavioral health. And for those of us in medical settings, you know, we have such a critical role to make sure that patients have a smooth transition to specialty behavioral health care, that we're closing referral loops. There's supports for those care transitions. And so we all work with patients that move in and out of these different settings, and I'll be kind of referring to this graphic along the way. You could go to the next slide. All right, so I'm going to kind of now dive a little bit more into what we're seeing with collaborative care and adaptations in the field. We're really seeing a growth in collaborative care across different patient populations and settings. Particularly, we are seeing this, for instance, in the perinatal population. How can we best support parents pre-postpartum care? How do we work with the parent's OB, PCP provider, and then making that connection with the baby's provider who's maybe screening the parent, and how does that look in team-based care in medical settings? We also have seen a lot of growth in pediatric collaborative care, so really thinking about the role of the parent and the caregiver in pediatric collaborative care. And in pediatric collaborative care, it's so important to think about the connections with the schools and community supports. How do you also do measurement-based care in pediatric collaborative care? And what does that look like, again, with caregivers, with schools, et cetera? We've also seen a lot of growth with older adults. I mean, the original collaborative care research at the IMPACT trial focused on older adults, but we're seeing it come back around now as people are thinking about how do you implement also collaborative care in long-term care settings? How do you really bring the caregiver into the mix with older adult populations too? There's been some more recent research around collaborative care and implementation with patients with more complex behavioral health conditions like PTSD and bipolar, and what do you need to do to augment the model for these populations? So maybe the episode of care in collaborative care is a little longer, or the caseload's a little smaller because the population's more complex. Maybe you also want to have the psychiatric provider, for instance, be a little more engaged in the initial assessment with these populations. So those are some ways we're seeing adaptations by population. We've also seen a lot of growth in different settings. We know that evidence is there for really good outcomes in rural settings. With the growth of virtual collaborative care, so having the behavioral health care manager and the psychiatric consultant be on like more of a virtual team. You can also, in more rural areas where there's a huge workforce shortage, you can provide that care sometimes virtually. We've seen this too in medical specialty settings where people are really thinking about collaborative care in oncology or in cardiology or other types of medical practices. And there are financial ways to now bill in other types of medical settings as well. I mentioned virtual care. I think that's been a huge growth with collaborative care, and there's been studies now showing really solid evidence around outcomes and virtual care. And then finally, I think in community behavioral health, as we think more about that behavioral health home kind of concept and see the growth of CCBHCs around our country, as people are adding primary care into a behavioral health agency, how can you also include collaborative care in the mix for patients with serious and more persistent mental illness? So those are just some of the trends we're seeing across populations and settings. Something else, so go ahead to the next slide. Something else we're seeing is also around the expansion of the workforce in collaborative care. With new funding strategies and growth in education programs, we've really seen the growth of that behavioral health care manager role. People are doing this in different ways. Now, sometimes there's now adding someone who is bachelor's level, who's maybe trained in social work psychology and some other integrated care training. I think with the right supervision and training program, you can have someone in this role with a bachelor's degree. We've seen growth with nurses. So this can be a really great strategy in rural areas. Maybe you have like a diabetes nurse who can also have a caseload of collaborative care patients, let's say, in a tiny clinic. It can also be a strategy now for workforce kind of expansion and like pipeline development. If you bring in associate level providers who are working towards licensure, there's opportunities to also train them as behavioral health care managers. We've seen some programs, what they're doing now too is adding additional what we call like a shared behavioral health care manager role. They're adding maybe a patient navigator or a community health worker or a medical assistant to the team. These roles can really help with things like addressing social drivers of health, maybe doing some home visits, helping with kind of engagement strategies, engaging hard to reach populations, collecting like the PHQ and making sure that's part of the registry. So people are really expanding their team as well. Other things we've seen with workforce are more partnerships happening. I mentioned virtual care being very popular for collaborative care. The benefit is, you know, the site consultant, the care manager, you don't have to worry about the hiring processes and all of that. You can work with a virtual company to help you with that. We see partnerships also in communities across specialty behavioral health and medical practices where maybe the specialty behavioral health setting, they're supervising the behavioral health clinicians, but the behavioral health clinicians are part of the medical practice. We've also seen a lot of growth around training programs and integrated care. And then finally with workforce, I just should mention technology. I think we'll talk about that later on. But people are layering in their collaborative care programs digital therapeutics or texting or thinking about ways to use AI to help augment their programs too. Go ahead to the next slide. All right, so just some final like keys to success when we think about collaborative care implementation. We've been doing this for over 20 years at the AIMS Center. And we know one of the critical things is identifying your champions and identifying them early, particularly your medical champion. Sometimes what happens is we have someone who's a psychiatrist in the community saying, man, access is such a challenge and I want to work with medical, but the medical practice isn't quite ready and on board to integrate care. And so really working to foster champions early is critical. Likewise, you want to foster behavioral health champions that are passionate about team-based care, models that work in a medical setting. And so having both is really important when you go to implement collaborative care. I also would really encourage programs to really think about what are their goals, you know, what's the need in their practice and in their community, and what are they trying to solve? Collaborative care might not be the right fit, and maybe it is a different integrated care approach, or maybe it's multiple approaches together. So just spending that time up front is really important. As programs think about sustainment and are sustaining and spreading their models, we really want to see them develop great clinical and financial metrics to help them monitor sustainment. Clinically, you know, are they getting better outcomes? Is access improving? Are they looking at things like engagement, key things that are part of collaborative care? Financially, are they looking at, you know, their payer mix and their revenue, and are they maximizing finance strategies as a program? So those are just some of the like keys to success and things we're thinking about. I'll end, if you're not familiar with us at the Ames Center, we have a lot of resources on our website. So I would just encourage people to check them out if you're interested in implementing collaborative care. We have a lot of DIY type resources. We have information about our monthly office hours. We had our finance office hours today. We do one on implementation and one for care managers. And then we also offer different training programs, whether that be skill training on brief interventions or asynchronous online modules for different roles on the collaborative care team. All right. So, oh, sorry, those are the resources.
Sorry, I forgot we had a slide on that. Thank you, Sarah. I'm already super excited about the moderated session because I have questions for you, but that was really exciting to hear what practices are doing and starting to implement and how they're thinking about it going into the future here and as well as today. So I'm going to hand it over to Dr. Jeff Reiter here. He is an expert in primary care behavioral health, so PCBH as the acronym goes. And he's worked in integrated care since 2002 across lots of sectors, community health, commercial and government sectors, and has supported lots of clinics and systems in their integration. He's also authored several books on how to do integrated care, and in his free time, I'll say, teaches at Arizona State University as well. So I will hand it over to you.
Okay, thanks, Annie, and thanks, Sarah, for starting us off. Yeah, I'm Jeff Reiter. I'm going to be talking for the next 10 minutes or so about, like the slide says here, the need for making primary care primary. This is regardless of the model or the approach that you use. I really think that this is an issue that is vital for the success and the sustainability of integrated care, is this need for making primary care primary, which I'll explain a little bit more about in the next few slides. But really, it's at some level, what you'll see that I'm going to be talking about is kind of a more specific, narrowly focused topic, which is the topic of when and how to refer to especially mental health. But that's embedded within this much broader topic, I think, that as I say, I think is really vital to the success and sustainability of our work, is the belief that we can really do a lot more in well-supported, well-integrated primary care than we often think that we can. So one challenge that I encounter a lot, like Annie was saying, I work with a lot of primary care systems that are working on integrating. And one challenge I see a lot is when there isn't that belief that primary care, that we really have a lot of potential for helping in primary care. A lot of times, whether it happens on both the PCP and the behavioral health side too, the clinicians fall into sort of what I call a triage and refer mode, where the first time that they see a patient, their primary objective seems to be to sort through, do I think I'm going to be able to help this person here in primary care, or am I going to need to refer them out to specialty care and get them help that way? And that just leads to lost opportunities left and right for helping people, and really, I believe, undermines the potential for success of integrated care. So hopefully, I can convey a little bit about why I think that just embracing the moment, embracing the opportunities that come up in primary care to help patients, and having a broad view of primary care is actually a wonderful place for helping many patients who have the full range of psychiatric and substance abuse problems, is really a beneficial perspective for us all to be taking. So we can go to the next slide. So, like I was saying, the issues here is that primary care, first off, is often viewed as an inappropriate setting for managing more complex mental health concerns. And by contrast, especially mental health, or SMH on my slides here, is often viewed as the appropriate setting, right? So when patients come into primary care, they have what is judged to be a complex problem. The goal is often, it seems to be, to kind of just get them into especially mental health. The hope being that they're going to take care of the problems and everything will be going swimmingly. The problem is that there's no standardized definition of complexity, though, right? So my definition of complexity and Neftali's definition of complexity might be very different. And what happens as a result is that for starters, there's wide variation in the care that patients get. If a patient comes to me in primary care as a behavioral health provider, and I decide, this is really, I think, too complex for me to handle here in primary care, I'd better refer them to specialty mental health. Uh, then they end up basically getting a referral from me. And if they go to Neftali and Neftali says, okay, well, let's take a look at how we can help with this, they jumps in and starts to help them there in primary care. That's just really wide variation in the care that patients get. And then the bigger issue that's related to that is that this really feeds into the problem that we as integrated behavioral health providers are actually in primary care to try to fix, which is the problem of access, right? So the whole reason that we are in primary care as behavioral health providers is because the vast majority of people whose health is being affected by behavior in some way uh, never will go to specialty mental health, right? And so when we come into primary care and we kind of fall into this triage and refer mode where we're referring out to specialty mental health, people that we deem to be too complex, it ends up, first off, in the patient, of course, not getting care there in primary care. And then we know that in all likelihood, they won't follow through with going to specialty mental health, which means that at some point in the near future, a couple weeks later, maybe they'll be right back in the primary care provider's office again for the same or some related problem. And we're actually in a little bit worse situation at that point because I, as the behavioral health provider in the clinic, have essentially cut myself off from being a resource for that patient in the future because I've told them that their problems are really too complex for me to work with there in primary care. So that cherished longitudinal relationship that is really the backbone of primary care, I've just taken some scissors to that. And so so I think that we can do better if we're really jumping in and embracing the moment with patients and trying to help. There's also a risk of potentially pathologizing patients, right? If you're sending patients the message that they're too complex, too complicated for working in primary care. And the irony of all of this is that the quality of care in specialty mental health is not necessarily better than what people would get if they were in primary care. We can go to the next slide. I think it's helpful sometimes to just reflect on all of the strengths that primary care has, especially integrated primary care when you have integrated behavioral health on site there, versus what a typical, especially outpatient mental health clinic has, right? So primary care has a multidisciplinary team. Maybe you have dietitians in your clinic and nurse educators. Of course, you have medical providers, behavioral health providers, and so forth. Um, if they go to a traditional mental health clinic, they have probably just therapists, maybe a psychiatrist who pokes in every once in a while. That's probably it, right? Primary care also knows about what's happening with all the specialty care that we get. They know what's happening with the patient's visits to neurology and to gastroenterology and so forth. That therapist that they get referred to out in the community doesn't know any of that, right? They don't have access to the EHR to gain any information about the patient. The patient's essentially a blank slate to them, right? Primary care, by contrast, has longitudinal knowledge of many patients, longitudinal relationships with many patients. They often know not only the patient, but their family members, their neighbors, and so forth. Relatively easy access in primary care. That's certainly no one has ever claimed that to be the case for specialty mental health, right? You have regular opportunities in primary care to engage patients when they're coming in for preventive care, acute care, chronic care. It's not the same as in specialty mental health when people go in for some kind of concern or problem that they have, and when that problem is deemed to be better, then the termination note gets written and there's no plan to ever see the person again, right? But in primary care, you have regular opportunities over time to engage patients, which makes it really an ideal place in a lot of ways for working with the kinds of chronic conditions that are basically define the sorts of mental health conditions that we work with. And then lastly, the ability to truly take a holistic approach in primary care, which isn't really there in specialty mental health. So if we can go to the next slide. So it's also true that especially mental health, isn't necessarily all that it's cooked up to be a lot of times, right? So for one thing, most patients don't engage in extended therapy. We know from many years of research now that the modal number of visits, especially mental health, is one. And on average, patients will keep 4 to 6 visits with a therapist. So, often in primary care, people, I hear this a lot from behavioral health and primary care providers. We need to get this person into specialty mental health so they can get long-term therapy that we can't do here. And but that's just not the way that people use specialty mental health most of the time. There's also no guarantee that referring to specialty mental health is going to result in evidence-based care. There's a lot of research that shows that many, if not most, mental health providers either don't get trained in evidence-based treatments or don't utilize them in their practice. And then it's also true that more therapy is not necessarily better therapy. So, no study has ever shown that if you have a 60-minute visit with the patient, you've hit the magic amount of time, right? That's better than the 30-minute visit that you could get in primary care, or a 15-minute visit, or what have you. There are plenty of studies in the brief therapy literature that show the value of brief interventions for a wide variety of problems. And from the PCBH literature, there have been studies that have shown that people actually report a stronger therapeutic alliance with a behavioral health consultant after just one visit than they do with the specialty mental health therapist after the first, second, third, or even the fourth visit. So, quite often I hear, well, they need more than this patient's going to need more than I can provide here in primary care, so I need to refer them out to specialty mental health. But more is not always better. We can go to the next slide. And this is my last slide. So where does all of this leave us? I mean, I'm throwing out some things here that I'm sure we'll probably circle back around to in our discussion time. But the first important point is that hopefully we can really believe in the potential of well-supported primary care and really believe that we can do a lot in primary care. And maybe alter our view of specialty mental health a little bit too. I prefer the language of especially mental health being a different type of care rather than a higher level of care or a higher, a step up or something like that you hear people talk about. So presenting it to patients and thinking of it ourselves as especially mental health as just a different type of care that maybe we could utilize if the person isn't improving in primary care. But trying to address patient concerns in primary care first, and then utilizing a different approach in especially mental health, or at least suggesting that if things aren't improving. And all of this kind of, I guess, can be summarized in the importance of just utilizing a patient-centered approach to referrals rather than a clinician-centered approach. So often what I see happen is that clinicians make referrals to especially mental health because of their own discomfort, feeling like they themselves, can't work with this problem that the patient is presenting with in the time that they have. And rather than making it a more patient-centered referral, if a patient tells me, hey, I appreciate that you do these 30-minute visits, but I really want 60-minute visits every week for the next 6 months. I've had that before with somebody. Okay, if that's their preference, I'm fine with that. Or, as I said before, if they're not improving in primary care, making their referral at that point, but really making our referrals more around what does the patient want and how is the patient doing, rather than a more clinician-centered approach. So anyway, I will leave it at that and turn it over to our next speaker. And as I say, happy to talk about any of these issues more in the discussion if needed.
Thank you. Thank you for talking us through or reminding us, I should say, about the potential and for primary care and sort of why we do what we do, bringing us back to the things we can do. Danielle put it in the chat. Thank you, Danielle. I forgot to mention it after Sara gave her remarks. So if you have comments or questions for Sara or Jeff or Neftali as they're speaking, please put those in the question and the Q&A box, and we will answer those at the end of the discussion or when we open up. So we'd like to have those on hand, but as they say them, please drop them in there if there's something that it sparks in your brain. So I'm going to introduce the last presenter, Neftali Serrano. He is the CEO of the Collaborative Family Healthcare Association, a nonprofit who works to advance integrated care. He's been doing this work for over 2 decades and is a widely recognized thought leader and trainer. He's also edited several books and handbooks on integrated care and also holds an adjunct teaching role at UNC's Department of Family Medicine. So Neftali, I will turn it over to you and then we'll open it up for the moderated panel.
Awesome. And thank you to Sara and Jeff. I'm going to have us go slide free because my job here is to ground us in a little bit of a summation of what has just been talked about, and then adding a little bit of the flavor from what's happening on the ground. In my role as CEO at CFHA, I have the privilege of being part of just a fantastic community of dedicated folks in the healthcare space. And that gives me and us as a community a bird's eye view of what's happening. And so I'm going to divide my remarks today in 2 parts. So I'm going to talk first in part A about the practice of PCBH and CoCM as we're seeing it happen live in the field. And so that's sort of like current state. And then in the second part, I'm going to talk about the evolution of those models, especially in the ever-changing and rapidly changing context of primary care going forward, to help us begin to think about how we may need to adapt this work going forward. So let's start with part A, the practice of PCBH and CoCM. In Sara's remarks, you heard some great insight into some of the emerging areas that CoCM is moving into, some of the open questions that are there as well. In Jeff's remarks, you heard about the importance of centering ourselves in primary care, and implicit in those was really a very PCBH-centric understanding of primary care and how to partner with care teams and patients. So what are we seeing actually happen on the ground? And just to give context, I'm coming at this from the standpoint of community conversations that we have. We have special interest groups in PCBH and CoCM and other important areas. We also have a consulting service, so we get into health systems and we get on the ground. So all of that's informing how we see these sort of theoretical models lived out in the real world. Well, here's some of the things we're seeing. One is more and more clinics and health systems are attempting to implement both. And oftentimes, this is referred to as a hybrid model or hybrid approach. And I understand why people might use that word, but I think that's actually a misnomer from what we're actually seeing. We're not seeing people mix and match PCBH and CoCM, the models. I think what people refer to when they say hybrid is that one clinic is running both models in parallel. So the word parallel is really more descriptive of what we're seeing on the ground. So PCBH had a little bit of a quicker start in the last 2 decades. And so what we're seeing a lot of is a lot of clinics that have had PCBH for a while, now adding CoCM into the mix as a parallel model, understanding that these models solve different problems, right? One of the best ways I think about what these models are trying to solve, CoCM is excellent at solving the continuity of care and quality of care problem that we have in primary care with complex conditions. That's why CoCM is very similar to the work we do in diabetes, for example. And PCBH is solving a very different problem. It's solving the issue of generalized access to behavioral health support across a range of clinical and non-clinical conditions. Awesome to have both of these. And that's what people are recognizing and doing more and more of. So parallel work. The other observation that we're seeing is that model purity is not common. So this is where there's a discrepancy there between what you see in the literature and then what you see in practice. This happens with every kind of practice there is, so it's not that uncommon. So how does this show up? Well, it shows up in a variety of different ways. So in CoCM, we'll see some sites where a care manager maybe only maintains a caseload of about 35 patients, whereas in the literature, you're supposed to be carrying something a little bit higher than that. But a lot of times you run into operational issues at the site level where that's about all you can do, right? You might have a 0.5 FTE care manager, for example. In PCBH, you may run into a situation like at my clinic, for example, where we actually have both PCBH and CoCM, where we don't have enough staff to cover the 40 plus providers we have. We have 1.25 FTE of behavioral health consultants. And so you're going to have to modify your model to a degree in order to meet that volume and demand. And so those challenges are what impact model purity. So model purity is not common. There's lots of adaptation that you see in the wild. The third comment I'll make here is that the level of integration matters. And this comes from some research that Dr. Dan Mullen and colleagues out of the University of Massachusetts just published last September that reaffirmed something that we were already seeing and sensing as a community, that it really matters the degree to which your organization is integrated across the clinical, the operational, and the financial. And the higher level of integration you have, as measured by tools like the practice integration profile, the PIP, that the folks at UMass built, the higher the level of integration, the better your patient outcomes are. And so generally speaking, when you do have higher levels of integration, you do have higher levels of model purity, right? And that means you've solved those clinical workflow issues. You've solved those operational issues. You've solved some of the cultural issues that impact the operational issues, and you've solved some of those financial issues. As a result, you are a transformed practice. That transformed practice has important outcomes. In fact, one of the interesting findings from that research was that it wasn't just the patients that had touches with behavioral health specifically that improved, but it was all patients, even those that didn't have touches with behavioral health, which is the goal of really good integrated care. The last thing I'll say here in this section is just tagging Jeff in this about the relationship with specialty care. We have not seen a robust improvement in the relationship between PCBH and CoCM implementations and specialty care. There's still a big gap there. Where there has been some improvement has been in just general availability, particularly for commercial patients, because of the advent of virtual care and services like BetterHelp. So it's a little bit easier to find. That doesn't always mean that it happens, however, as Jeff talked about. So that's a little bit about where we are right now. Of course, I can say a lot more about implementation in the real world. That should give us a lot to talk about. Now, I'd like to transition from here, where we are, to what we are feeling is coming up ahead. And here I really do want to light a fire under each of us here today, because I believe that the next 3 to 5 years is going to be really, really important for us in healthcare and in primary care in particular. There are major shifts happening under our feet that if we don't pay attention to them, they're going to happen to us instead of us participating in that change. So one of the things that we see as an example of this are like virtual integrations, right? Sara alluded to many of these. In CoCM, there's a lot of health technology companies that are integrating into clinics with CoCM. So you have the opportunity to outsource CoCM with PCBH in particular. You have lots of companies attempting to partner with primary care to outsource behavioral health support. And it's still an open question how this impacts fragmentation and fragmentation of care. But that is a trend that's going to grow. The other trend that's related to that are AI opportunities. In other words, are there some opportunities where, well, there are going to be increasing opportunities where artificial intelligence is going to change the way we work. We already see some of that with documentation support, right? But it's going to go way beyond that. There's going to be improvements in workforce development, the feedback tools that give feedback to therapists, for example. There's going to be tools that are patient-facing, where a patient can journal to an AI bot, and that information will go to the therapist. So there's lots of opportunities there. How those are shaped becomes super duper important. And then the last just sort of mini example of many changes I see happening is the economic reality around primary care. And I'm going to use a phrase, I don't want it to sound pejorative, I just want it to be descriptive without any judgment. But it's sort of like economic vulture capitalism. So there's a lot of companies right now that are trying to eat away at the edges of primary care. Think about companies like Row.co or Hims and Hers that are offering different treatments that are traditional to primary care, maybe for weight loss or ED, or virtual care services that are trying to take sort of the easy virtual care, things that can be handled in virtual care. So I think this presents really good opportunities because access to primary care is an issue in our country, especially in rural areas. And so this will present opportunities for improvements in that area. However, it also presents, and all of these things I've just mentioned, presents challenges that run counter to what we've been working on over these last couple of decades. It may increase fragmentation in care and may reduce the push towards interdisciplinary team-based care. So our challenge as a community, and my challenge to all of you, is for us to pick our heads up. Yes, we need to pay attention to these models and to the developments that each of these models need. There are things we need to still work on to refine CoCM, especially on the billing side, and refine PCBH as well in practice. But there are these larger issues that actually will dictate a lot of what's going to happen with and to us in primary care over these next 3 to 5 years. And so we have to be in conversation with the health tech companies, with the payers, with the systems that are adopting the AI tools, so that we make sure that we prioritize defragmented, whole person, integrated, team-based care. All right, I'll leave my comments there and return it back to the general conversation. Thank you.
Thank you, Neftali. I have lots of thoughts, so I'm just going to thank you for your comments and hand it over to Jody to take us into the moderated panel discussion. I see questions coming into the chat, so please continue to put those in because we're going to do this for a little while, and then we'll have about 30 minutes at the end to get to those questions. So thank you.
Great. Thank you, Annie, for leading us through all of that. And thank you to this real power panel of speakers. It was just a joy to hear each of you and those different perspectives that you brought to the group of us today. Also, thank you to our attendees. I had a minute to scroll through the list of folks on the call today. We have some amazing folks in the integrated behavioral health world. Frankly, anyone in the integrated behavioral health world is amazing in my view. And it's always just really nice to be together with people who are doing this work and support one another and hear each other's stories, because we all know it's hard work and we need each other. So thank you for taking the time today. Also, you all are awesome because you did all the work for me and submitted many questions in advance. So we were able to take those and build those into a little bit of a format here for my moderated portion. And I'm going to bust through it a little bit so we can get to your questions you have now that you've heard the speakers. So the first is an opening frame, a quick kind of lightning round. I want each of our panelists to answer in just a sentence or so, and I'll call on each of you so you don't have to sit there anxiously wondering. The question is, what feels most different about integrated behavioral health today compared to a few years ago? Neftali, you're up first.
There are so many more resources available for you to get the job done. And so my message to you all out there is, if you're hitting pain points, that's normal. You should not be troubleshooting those by yourself. Between the AIMS Center, if you're looking at CoCM, ourselves, also we have CoCM resources, the CoCM SIG, PCBH SIG. There's and then training programs at UMass and others. You should not be going after this alone.
That's great. And don't forget the Integration Academy. Of course, I'll throw that one in there. Sarah.
I mean, I'm excited about the growth in kind of financial strategies for your integrated behavioral health program. We've really seen that growth roll with Medicare and more with Medicaid and commercial payers too, and different changes that have happened in our landscape to make our programs more financially sustainable. So that's one thing I'm really excited about seeing.
Thank you. And Jeff, what feels different? You're muted.
I knew I was going to do that at some point. Got out of the way right up front. I think that what feels different is that we're not having arguments anymore or so many discussions around, is this a helpful thing to do? It's much more widely accepted. I can remember the early days of integrated care when it was like, you're going to sit with somebody for 30 minutes? What can you possibly do in 30 minutes, right? Isn't that unethical? Is immoral? I don't know, whatever terrible label you want to put on it, right? Terrible care. And I just don't hear those discussions anymore. So I think that there's a much greater understanding about it, and acceptance of it, which is great. And I think that the one last thing I'll sneak in here is, I saw a statistic recently that 19% of the behavioral health workforce now works in primary care. That's a lot of people, right? So there are a lot of people working in integrated primary care in some capacity right now, and that number would have been different for sure, 10 years ago.
Great. Thank you. I'm going to move into another question. And for the panelists, I'm going to skip the future of models section and jump right into PCP buy-in. And really, each of you presented content that really provokes the thinking around, hey, this sounds like it'll work. How do we get primary care providers to refer to the collaborative care model? Or in Jeff's case, how do we get primary care providers to understand that something can be done today and not necessarily that there's something better out there in specialty mental health? And certainly, Neftali, how do we get primary care providers to help us move that level of integration up to the highest level? We have to have them on board, right? So I'm going to lead with Jeff. If you'll answer first, how do we increase PCP utilization and buy-in for integrated behavioral health?
Well, it's a good question. I say it's a good question because I get that question all the time when I'm working with systems that are working on integrating, and it's sort of this irony, right? Because supposedly the reason that we're in primary care is because primary care is overwhelmed with patients whose health is being affected by behavior and emotions in some way, and then this integrated service, comes online, and like I say, it's one of the most common questions I get is, why aren't I seeing more patients, right? So there are a lot of reasons for that, but I can, if I was to sort of break it down to what I think is the most important, it's that there are an awful lot of competing priorities in primary care. Uh, Primary care providers, most of them would probably love to get us behavioral health providers involved on a very regular basis with their patients, but there are also a lot of other things they'd like to do, and they, on a regular basis with their patients, and they just, don't necessarily have time for it, right? A lot of you have probably seen those studies that were done a while back that I'm sure still hold true today about in order to implement all of the the preventive care recommendations of the USPSTF. A PCP would need 8 additional hours per day, right? So there are just a lot of competing priorities, and I think that in order to move past that and keep yourself on the PCP's radar, there are a couple things you need to do. I mean, one is you need to provide a high quality intervention to the patient. So, making sure that you're using evidence-based strategies, you're listening well, you're utilizing a patient-centered approach, so patients come away from the encounter really feeling like, wow, that was really helpful. And they come back and they tell their primary care provider about that. But there's also, I think, it's also very important to show the primary care providers how you can help them, right? Because, if you come in solely making the outcomes argument to primary care providers, meaning we're going to be able to improve outcomes of your patients by incorporating me more into care. Primary care providers, they believe that. They'll be on board with that. But if it means also that it's going to take a lot more time for them, or it's going to put a lot more work on their plate to do that, it's just the reality that you're not going to rise to the top of the priority list. So I think it's really important that we're thinking not just about how do we help patients, but how do we help the whole team here in primary care and really help them all to just even just help them get through their day more easily. If we catch wind of a patient that brought an 8-page disability form, for PTSD into their PCP and wants them to fill it out, well, I can ask the PCP, hey, can you have the patient see me? I can sit down with them for a visit right now and do that form instead of you with them, right? Or, you got a patient who got referred for an ADHD workup. Well, that's a time-intensive workup. How about if I collect the Vanderbilts for you and collect the history around that, and look for ways to take the work off of the PCP's plate. That will really make you stand out. So that's I think how I would kind of summarize it.
That's really helpful. Really thinking about yourself as a team member in a broader way and jumping in there. Sarah, anything quick you'd add to that from a CoCM perspective?
I think just really being present. We talked already about the role of the PCP champion and their buy-in, but as behavioral health clinicians, as you integrate, being at the staff meeting, being in the huddle, like especially at the beginning, as Jeff's been talking about, PCPs have so much on their plate. There's always the newest program of the month or the newest thing they're adding to primary care. So you got to be present. And also showing up with some really great success stories of team-based care and how working with the site consultant, we're seeing this patient get better, and this is the great recommendation that we got, and all of that. So those are some little quick tips I would share.
Great, thank you. Of course, none of this works unless things are sustainable in the long run. So just a switch, and Sarah, we'll start with you on this one. If an organization wants their integrated behavioral health program to be financially sustainable today, what are some strategies that you would recommend?
I'd start first by looking at what is your payer mix and what codes are your payers covering. I mentioned earlier that there are a lot more codes, a lot more payers covering these codes, but it's also a bit hit or miss across the country with Medicaid and commercial payers sometimes still. So I would take stock of who are your payers, what are their requirements and what types of approaches are they paying for? That will help also guide you then too, and who you also might want to hire and what approach you might want to start with if you can figure out your financial plan, and then doing some financial modeling, some pro forma work to kind of figure out what's going to make the most sense. And it's always this kind of mix of what financially will make sense, but also clinically kind of what's the right model that our organization wants to try out first. So those are some things to think about.
That's great, thank you. Neftali, anything you would add to that?
No, I mean, I think that answer is on point. I think, be really practical about the change you're going to embark on whenever you're doing this, right? So every change is a culture change. So you have to be thinking about this just the same way you did MAT at some point in your organization's life history. rinse and repeat those patterns. You've learned things already in terms of those other changes. Did you implement a care management scheme at some point with your nurses? And did you learn some things there about how change happens in your organization? This is no different, really, than those other cultural changes within your organization.
Great, thank you. Okay, and then this question will be for you, Neftali, just pivoting like to what's coming next. And I think you do a great job in general of helping us look to that leading edge. What might we see AI used in integrated behavioral health settings in the next few years? You mentioned a few. Can you talk about that a little bit more?
Where won't it be used is really the answer to that question. The real question is, where will it be effectively used? There's going to be a lot of attempts, so get used to it. There's going to be a lot of attempts, and a lot of them will fail, and a few of them will survive. One of the attempts that I can speak to that I'm probably most excited about, because as Jeff mentioned before, there is a quality of care issue in terms of the provision of behavioral intervention just across the board. We've got way too many license types, way too many training backgrounds, and a lot of inconsistency there in the output. So imagine this, you're a clinician, you're in an exam room, you've got your phone open or a laptop, and you're with a patient, and the AI is listening to your conversation. And as you're in the conversation, the AI is prompting you. This might be a good question to ask. This is something you may have missed. Make sure you complete this assessment as a way of hewing the clinician towards an evidence-based pathway. Now, we can all agree that that could go wildly wrong and bad, right, in terms of interaction with the patient and being present. But I think, also can see some opportunity there, right? Add to that the layer of you as a clinician are now not only needing to depend just on what you do with the patient in the room, but asynchronous contact with the patient. I mentioned this before, this is actually a real app, patient journals into their phone as part of their homework. AI sends a summary of that to the clinician in between visits, and the clinician has an opportunity to respond or cue the patient in a positive direction, right? That expands our ability to intervene beyond just the visit, right? And this cuts across CoCM and PCBH, right? This is trans model. So there's opportunities. I'm not blind to the good that could come from that, but I am concerned that because we're not conversing with health tech companies as much as we should be, and these companies that I do talk to quite a bit are not in our worlds, really. They're in the world of venture capital. That what products they develop are not the products we actually need, and that there are byproducts of those products that we may then have to fix on the back end.
That's so interesting. I remember back in the day, the American Telemedicine Association was one that did a good job of crossing health tech with providers, but man, it's moving fast. So there's a lot of opportunity there. Jeff, did you have any thoughts about how this might affect care utilization? Anything you would add to Neftali's comments?
Yeah, I mean, so Neftali was kind of speaking to some points there about quality. I'm always interested in the access angle, access to care angle. I'm actually really excited from an access to care standpoint. I'm really excited about, what the future holds in terms of having more options available to patients. I mean, to Sarah's point in her, I think, first slide, it's so important to just have a variety of options for people, because no one approach is going to work for everybody, right? I think having more accessible, digital and AI sorts of interventions for patients is going to be enormously helpful for a lot of people. And I do think it will change access to care in a lot of ways that are good. At the same time, I also believe that there's always going to be a need for us in primary care because of it goes back to what I was just saying about no one intervention works for everybody, right? So there will be people who benefit from self-care or help with, digital interventions, AI interventions, and there will be plenty of people who don't. And most of those folks are the ones who come to primary care, right? So if I was in the specialty mental health world, I'd be a little more concerned about, I think a lot of the AI and digital interventions will sort of maybe siphon off a lot of the low-hanging fruit, the patients who are more motivated for care and psychologically minded and comfortable with technology and so forth. But your typical patient who comes to primary care, whose health is being affected by behavior in some way and just wants to come in and get a pill and get out, there's going to be still lots of opportunity for us to help in other ways. So it's all hands on deck, I guess.
I'm glad to hear the forecast that primary care will still be a relationships business. That's what I love about it the most. Sara, I'll give you a quick minute. Do you have anything you would add to that little bit there? That was an interesting round.
Yeah, definitely. I just think from a collaborative care perspective, breaking down, I think AI, there's some benefits there. If you think about the tasks of collaborative care and like as a program, what are your sticking points? So if it's around data and the registry, like could you use AI for like some BI, business intelligence tools, some decision support tools that helps augment the systematic caseload review, let's say.
Right.
If it's around engagement more, and is there something that could be done to help engage patients using AI?
Right.
So just there are opportunities and there are risks that everyone's been talking about, but that's kind of where I would start.
Yeah, sure. Great thoughts. All of them were. We'll close real quick with a lightning round. And while we're on this lightning round, if you're one of our viewers, don't forget you can type your questions into the Q&A box because we'll get to that next. And so the question is, and we'll start with Jeff, what's one active ingredient that will define successful integrated care programs over the next 5 years?
I think I would probably hone in on access or being, accessibility. That wouldn't have been a different answer probably 5 years ago if you had asked me either. I think that's why we're there, right? That's why we're in primary care, is because we're there to help solve an access problem where most people don't utilize, especially mental health. So, but but yet what I see happening out in the field left and right is that even these integrated care programs in primary care are not always all that accessible, right? And that really leads to them being not maximizing their potential, I don't think.
Sure,
Right?
underpowered. Yeah, sure. That's great. Quick answer, Sara, active ingredient?
Yeah, I don't think mine would have changed over the last 5 years, but I'd say the engaged primary care team, like we've been talking about, just really having an engaged team and engaged PCPs that are excited to make the change in primary care would be my active ingredient.
That's great. Thank you. And last but not least, Neftali, active ingredient.
I totally agree with Sara and Jeff's active ingredients. I'll just add a dash of measurement. And I say measurement not just for measurement's own sake, but because if you're measuring, it is indicative of some of the transformation you've already done.
That's right. Measurement in clinical care. That's really helpful. Awesome. This was a great panel discussion. I enjoyed it. I didn't completely stick to the script, but you all did a fantastic job of rolling with it. And now we really go off script and we take questions from the audience. We already have a few in the Q&A. Annie's been monitoring those. I'm going to pass it off to Annie to give you the first one.
Thanks, Jody. I'll let you have a chance to review them. There's a lot of questions in there, but I see a question that actually, I think it's in there 3 times, some flavor of it. So I'm going to direct it to Sara first, but obviously Jeff and Neftali, feel free to weigh in too. People are saying that they're currently at a clinic that has a co-located behavioral health and primary care, and what requirements or what prerequisites or what cultural shifts are required to move on that continuum of truly integrated care. So yeah, what would you throw out? I know there's a lot. That's a loaded question, but
Yeah,
what's the next step?
yeah, for sure. I mean, I think it goes back to what are the goals of your program. You know, if it's around like treatment and access, and then maybe collaborative care is the right approach. You have to be okay with you're going to follow patients for an episode of care, but if you're having trouble getting patients into psychiatry or therapy, et cetera, then really providing this care within primary care for an episode of care, bringing the consulting psychiatrist and care manager in. But if it's more around like PCP burnout and like really needing like someone alongside the PCPs during the day, then maybe PCBH is the right model and approach for your clinic to be shifting to. So I think it's kind of understanding the goals and the pain points in primary care before like figuring out the next steps that you might do in the continuum of care. Those are some ideas.
Yeah, I'll jump in and just say that it is exceptionally challenging. This is a perspective of sort of real world implementation. It is exceptionally challenging when you have a pre-existing behavioral health department to then transition your practice to an integrated setting. Because you are doubling the cultural lift and you're doubling the operational integration work and you're doubling the training work that you need to do. So I say that not to discourage you, but just to be reality based. More often than not, when we go into a system that does have integrated care, and if that system has decided that they are going to basically go whole hog into integrated care, what you often find is that the behavioral health department, the folks working there, the therapists leave because it's not what they signed up for. And I get that. That makes sense, right? It's not what they signed up for. It's not what they want. It's not aligned with their values. And then the organization has to go through a shift. It is possible to retain a specialty-based therapy service and then build in a CoCM or PCBH model that runs alongside that. But I frankly have not seen it yet, and I've been doing this for a long time, successful where you are able to successfully transition a department from being co-located to then being integrated. You're usually building an integrated service within primary care and leaving the specialty care service alone or modifying it in some way that just is different than that. So that's just a real world answer.
And I think I typed in this answer, but I'll speak it as well, that if you do have motivated clinicians who want to be in primary care, the most important strategy, I think, for making better integration happen is just to locate yourself in the right place. It's very straightforward. Seems simple enough. But just locating yourself where the primary care providers are. Not every clinic obviously has a hub where everybody sits when they're not seeing patients, but if you do have that kind of a space, there's just nothing more beneficial than locating yourself there. That's where so much spontaneous teamwork comes from and spontaneous learning comes from. And people will just think to utilize you a lot more when they see you. Even if you're just one office door down and they don't see you, you don't get utilized as often. So anyway, location, location, location.
And that applies equally for PCBH and CoCM. The best care managers are going to be the ones that have built real relationships with their teams so that their teams know who they are and have trust in them. Same thing with a consulting psychiatrist. If they never step foot in a clinic, it is really tough to get buy-in from providers who are actually doing the prescribing work.
I got a question here from one of our physician champions that happens to be in our audience today. And she wonders, do you feel that our PCPs And I mean, big picture, like professional organization, the collective voice of PCPs are advocating or at the table or helping build integrated behavioral health. And I guess I would just add to that question, if not, like, how do we get them there?
Yeah, I would just say yes, and there's more that needs to be done. I mean, I know there have been a lot different medical associations that have done like position statements or papers. I'm thinking about Academy of Pediatrics, American Medical Association's been having different series on integrated care and engaging different medical providers. I think oncology just came out with something as well. So I'm seeing the medical associations come out with statements or kind of best practices, but I think there's so much opportunity too, Dr. Thomas. So.
And I also feel like I'm seeing more and more of these medical groups focus on training their own medical providers to feel more comfortable working with mental health concerns, which is great, but it's also I fear a little bit of a reaction to there's a lot of integrated care that maybe isn't meeting needs out there, and so it leaves the primary care provider still feeling like, okay, we need to figure out a way to help ourselves here more. I mean, I don't know if that's the discussion that's happening, in those organizations, but that's the sort of the sense that I get when I'm having a bad day. That's why I just, really preach about the importance of making ourselves as useful to primary care as possible so that they really see us as not just a service that's nice to have, but it's something that's really necessary in order for them to do their job.
I'll just chime in very quickly that yes to all of the above that's been said, and we do need more physician champions. We need, as was noted in the chat, we need more NP champions. We need more PA champions. They're actually the future of the workforce numerically, right? So we need those folks on board as well. But I would encourage the audience to also think about, we actually need, and I know you're going to go to this next, Jody, with CJ. So the area that I've been thinking more about is actually the operations area, because I think we've done a lot on CJ's clinical side and on financial side, but have we influenced the operations side? And that's interesting because I asked myself that question the other day, and I thought to myself, how many operations people within payers, within health systems, within our clinics are deeply imbued with an understanding of team-based integrated care? And I really couldn't think of a whole lot of great examples of that. And I actually think that's the area where we need more champions. We need champions at the operations level at each of these levels of the health system.
Agree. And thanks for reading ahead. I don't even need to be here. You guys can just read the questions that I check off and just keep going. But we did have a really great question come through, and it had to do with growing evidence or a research base for operations, for use by policymakers, for use by insurers, people who are implementing in integrated behavioral health. And the questioner asked this question in the context of, we have these different models and we have people doing them in parallel, and we have all this variability in how people are implementing integrated behavioral health. Doesn't that make it hard to create a coherent body of science? Do we need that? How do we move forward on influencing in the way we could with the evidence base? It's a hard question.
Well, I will start with a little bit of humility in that to say, honestly, I don't know. I think it's important to know that. I think there's so much changing in the healthcare space that it's hard to know. It's hard to know where the next sort of key intervention point is in the system. What I will say is that, and this goes to the remarks that I had earlier, what we do want to do is not do certain things. And one of that is be myopic about our areas of interest. We don't realize this, but because we are birthed out of academics, our perspective becomes myopic and we're encouraged to be myopic pretty quickly, right? And so we become like champions of PCBH or champions of CoCM or champions of substance abuse care integration or whatever it is might be. And that's important and necessary because we need people to hone in and solve some of the problems that are in this chat right today, right? Solve specific problems to CoCM and enrollment. And hopefully at some point we can get rid of the physician attestation portion of all that, right? That's important. And we really have to zoom out a little bit more now that we've made a lot of progress in terms of visibility of these integrated care approaches. It's in federal legislation. It's well known by many people in healthcare and power. We need to connect what we're doing with some of those larger changes that are coming up ahead. Because I think of it like a tsunami, right? And we're all on the beach building sandcastles. We're like, oh, look at my nice little CoCM sandcastle. Oh, look at my nice little PCBH sandcastle. And then there's a big tsunami coming, and it's just going to wipe those out, right? So I think we need to just look at the tsunami and say, all right, how do we start answering some of the questions that healthcare is facing around affordability? How do we answer some of those questions around the way that health technology is changing things? And how do we use our lived experience as people who are very good at defragmenting care, who are very good at team-based care and interdisciplinary work and understanding how teams work? How do we create influence that change that's happening so that it aligns with the core principles that we know work, especially for patients with complex conditions? I think something in that direction is where I'd like to see us go.
So keeping an eye on the future and what's coming, and if we all kind of are focusing on measuring kind of common dependent variables, if you will, based on what we know it matters in integrated behavioral health, hopefully all those different kinds of things will come together. Other thoughts on that one? That's a big question.
I mean, I guess I'm not sure that we need to have like, some sort of coherent, this is integrated care and it works study, because we have a lot of different ways of doing integrated care. It's not that different from the psychotherapy literature. You have studies of CBT approaches, you have studies of ACT approaches, and yet we talk about generally about, is therapy effective, right? And we answer that question of, is therapy effective, by reflecting on, well, I read this study about CBT was helpful for this, or interpersonal psychotherapy was helpful for that. And so, but I think that what is important is to make sure that what we are doing with our individual approaches gets as much empirical attention as possible, and good empirical attention, and yeah, maybe we can learn along the way about some common factors that are helpful, which is what's been happening in the psychotherapy literature too, I suppose. But anyway, those are my thoughts about that, I guess.
Great. Sarah, any quick adds to that?
Yeah, I mean, I think we have this potpourri of like a lot of different great approaches at this point. And there's not going to be one standard out there for our practice based on, population, community needs, what we've been talking about. I do agree, like more and more showing examples of how people are blending these approaches, blending funding models. I think that can be helpful for people to give them concrete ways to do this. But it's an exciting time for integrated behavioral health. There's a lot out there right now and a lot of support out there too, like Neftali mentioned earlier too. So
it's great. In the last few minutes, I just thought we would answer a question that came through about where to access key training materials, especially free resources for getting some training in PCBH or the collaborative care model. I'll kick this to Sara first. If you want to just give us a couple of really great specific things that you love that are available for free, or even some of the ones that you think would be worth a few bucks on the Ames Center site. And then we'll come to others for their thoughts, and we'll finish that round with Annie talking about some of the stuff in the academy.
Sure, definitely. I mean, I mentioned our website for the Ames Center that has a ton of really great free resources. A couple that come to mind, we have a couple of implementation guides, one specific to pediatric collaborative care, one more general around implementation of collaborative care. The APA several years ago came out with online modules that are free that for the psychiatric consultant role and the PCP and PCP champion role. So I'd highly recommend those. I will put those in the chat. We have really comprehensive training for behavioral health care managers that you do have to pay for their online modules, but I'd recommend them for just a foundation for anyone going into that role as a behavioral health care manager. And then lean into our office hours at the Ames Center, because that's a really great, people are always sharing resources and getting best practices from other practices around the country. So those are a couple. I'll work to put a couple of those links into the chat, Jody.
Thank you so much, Sara. We started a collaborative care model pilot in our pediatrics clinic not too long ago and found those resources to be incredibly helpful. Jeff or Neftali, or let's start with Jeff, maybe any thought on, your favorite trainings or resources that you point folks to?
Well, I'll say I've been envious of the Ames Center for many, many years because it's such a great resource for people who want to do the collaborative care model. I've used it many times myself, that website. It's great. I wish we had something similar to that for PCBH. We don't. We don't have really any, centralized resource for PCBH. But if anybody has any grant funding out there that they'd like to use to develop that, hey, give me a shout. But as far, I think most people who are learning to do PCBH just take up trainings on their own from CFHA. Neftali, I'm sure, can speak to the trainings that are offered, through CFHA. There, a lot of the trainings that UMass does are applicable, I think. I've seen, I think, is it the Meadows Health Institute that just started up a new PCBH offering, I think, too. So, it's people just kind of piece it together. I always encourage people, frankly, if you want to really learn how to do PCBH well, learn about primary care. I encourage people just to read primary care journals and to familiarize themselves with the top issues that are going on in primary care and the kinds of problems that they're facing, and learn how primary care providers work with different problems. I think there's a tremendous amount that we can benefit from when we do that. So, but other than that, I'll turn over to Neftali. I'm sure you have a lot of ideas there.
Yeah, the first thing is, Lou, there's nothing free in life. Somebody's paying for it. So if you want free, just search PCBH on YouTube, and you're going to find some videos from David Bauman and Bridget Beachy. That will give you a great orientation to PCBH right from the get-go. I've got some older videos, but I don't have gray hair in those videos. That tells you how long ago I've updated those videos. But you'll find a lot of information there. There's also on CFHA's website, cfha.net, under the resources tab. There are lots of free resources there. And if you join CFHA, not free, but you're going to be getting free sort of technical assistance in a sense from your peers in the PCBH or the CoCM special interest groups or both. And that honestly is really worth its weight in gold in terms of just dealing with practical things that questions that you have. And then, of course, there are formalized trainings that you have that Jeff talked about, UMass, and then our stuff on our events tab on the CFHA.net website.
Thank you, Neftali. And thank you to all three of you. It's been wonderful spending some time with you this afternoon. I'm going to pass it off to Annie. She also can talk about some resources that are available through the Integration Academy. Thanks to all of you for hearing me today.
Yeah, thank you all again. I want to echo Jody's thanks. This was a really fun webinar. I learned a lot, and I think I just feel grateful to have three champions of IBH in the room together and have been able to ask them questions. So I'm going to share our last slide here. Let me click the share button. There we go. So we just, as Jody mentioned, we have a lot of resources on our Integration Academy website as well. I'm going to highlight a couple here that I thought of as questions were coming in, but there's a lot more on the website. So we have playbooks, an integrated behavioral health playbook, as well as an MOUD playbook, and those are really, they're both updated, and the MOUD one is new, but those are really meant to be guide yourself, sort of choose your own adventures, but what you need, work on those modules, and so that can be, depending on where you're at, really a good place to start. We also do topic briefs, a couple each year. So two of our most recent ones were on suicidality and integrated health or integrated behavioral health, as well as pediatrics. And so we talked a little bit about both of those today, but that those topic briefs are available, as well as a slew of other topics. I saw Danielle put in the chat the ecosystem. That's a great place to start, just to see who else is doing this work and has these resources. We reach out to that ecosystem to update the things they're doing and put those in our newsletters as they come out. But that's always a great place to start to see who else is doing this work. And she also put in that we have a financing toolkit coming up, so we're really looking forward to that. It should be out hopefully before summer, but it's mostly complete, and we're really looking forward to that resource coming out. Similar to the playbooks, it's sort of a where are you and what resources can be helpful. You can sort of guide yourself through that toolkit as well. So just I put up on the screen here our Academy email, so academyportal@westat.com. That's how you can get a hold of us. We love feedback on our products or suggestions for new products or new webinars or webinar speakers. All feedback is welcome there, as well as you can use that to sign up for our newsletter, which is on the right there. So integrationacademy.ahrq.gov and then /academy-newsletter. And you can get our newsletter, which collates a lot of resources, including our partners, that Neftali from CFHA and Sarah from the AIMS Center. We work to make sure we're getting out the latest and greatest on integration to you all. So thank you again to our presenters, and we wish you a very good rest of your Wednesday and your week. Thank you so much.